Welcome everyone to this oral presentation on efficacy of a novel brief motivational intervention for alcohol intoxicated youth adults in the emergency department, a randomized control trial. Your speaker will be Dr. Jacques Gaume, and he's from the university. His organization is Lausanne University Hospital. My name is Paul Carvalho. I will be your host for today for this session, and my co-host will be Jocelyn D'Souza. If you all have any questions, please feel free to use the Q&A tab on your right hand side just next to the chat. Over to you, Doctor.
Okay, thank you, and thank you all for joining for this session. I'll share my screen. It's working. Here we go. Do you see it well?
Yes, perfect.
Okay, so I start. So yeah, it's I will present this study that we just completed, a randomized control trial about the efficacy of a novel brief motivational intervention for alcohol intoxicated young adults in the ED. And I first wish to thank my co-authors, Nicola Berthollet, Molly McGill, Jim McCambridge, Olivier Ugly, and Jean-Bernard Deppen for this work. So, and it's not working. Okay. So yeah, heavy drinking among young adults is a major public health concern. I don't need to say a lot about that here, I think. And also we have a study a few years ago where we looked at young adults admitted in the emergency department in Lausanne, and while they were intoxicated, and we thought that they had really poor health outcome. That was 6 years later, and they had major rates of readmission in the ED, alcohol use disorder, other substance use disorder like cocaine use, marijuana use, tobacco. Also, mental health outcomes were really bad and higher rates of unemployment. So it really looked like we need some prevention measures for these young adults admitted while they're intoxicated in the emergency department. And brief motivational interventions or brief motivational interviewing in the ED have shown promising but inconsistent results. If you look at the systematic reviews, it's not that clear that it works. It works in some cases, it doesn't work in other cases. So we designed the project in 3 phases. The first phase was to develop a new or to adapt an intervention model based on what we know could be the components of an effective intervention, and we pre-tested it, and we did qualitative interviews with people and with experts in the domain, and it was just published this year. So this was the first phase development. Then we tested the efficacy of the intervention, that's what I will present, the randomized control trial. And then we also tape recorded all the sessions, and we want to explore the exact mechanisms for whom it's working and in which conditions. And the idea is to finalize then the model and disseminate it. So this is the brief MI model. This is just an outline of the model. I don't want to go into too much details, but the idea is to take time to build a significant relationship. So working with empathy and acceptance and alliance and really work on these MI skills to build something significant with the patient. Then there is the change talk, so a lot of focus on change talk and avoiding sustained talk, and also give some information, give some advice within the ED that it was an important piece. And this is transversal, so that's for throughout the session, we want to build on these 3 strategies. And then the steps, it's really based on MI. So first, we would like to explore the current situation and see if there are problems and important things in life that doesn't match with this current situation. Then evoke some change, look in the future, say if you have if you can wish something, what situation would you like to be in? And then the next phase, the third step was to really plan in some concrete steps what you can really commit to do right now. And then we summarized it, and we had a feedback letter that we sent to the young adults, and then also booster sessions. I will come to that later. And we compared this brief MI model to a standardized brief advice. It was really short brief advice, 3 to 5 minutes, based on the audit score. So if there was hazardous use, we just gave a feedback that you have hazardous use. If it was more than 16, we refer to treatment. So we give a little leaflet with information about the treatment facilities in Lausanne. We also give information about effects of alcohol on health and give the classical recommendation guidelines, NIAAA guidelines for low risk drinking. The study flow chart for this RCT was that we had every young adult 18 to 35 years old admitted in the ED with alcohol intoxication were eligible. There were 2,100 of them. There were exclusion criteria such as life-threatening conditions, death needs, and medical legal admissions, psychiatric or medical contraindication. Those were not fluent in French, because we speak French in Lausanne. Current alcohol and substance treatment, ongoing treatment. So those that were not well enough to sign consent because they were too intoxicated at the moment, and people that were already included in the study then came back, we didn't include them again. There were also people that left the ED before meeting the staff, and we tried to reach them and make them come back, but for some of them, inclusion was not feasible within 10 days, or we couldn't reach them to propose inclusion, or there was an inclusion set, but it was missed by their people. There was a refusal. About a quarter of them refused to participate. They were eligible, but refused to participate in the study. Some early dropouts. And so we could, in the end, have consent, informed consent, and baseline assessment for 344, which was the sample size that we estimated was needed for this study. So it was randomized 1-1 to brief advice or motivation intervention. And we had booster session at 1 week. So it was only for motivational interventions. We wanted to see, are you okay we call you and continue the discussion. And it was at 1 week, at 1 month, and at 3 months. And you see here that the follow-up was quite good in these booster sessions. And the actual follow-up for the study at 1 month, 3 months, 6 months, and 12 months. And we see that overall there were about 80% follow-up rate. A few baseline descriptives about the sample. There were no significant difference between group, and there was about a quarter of female. Mean age was 24. Audit score was also about 14 on average. Heavy drinking days, so that we asked the number of heavy drinking days over the last month. There were about 3 to 4. And readiness to change was medium to high level. We tape recorded every session for the mechanism study, but also to assess intervention fidelity. And so the brief advice were 3 minutes overall, and the brief MI was 38 minutes on average. And these are the MIGHTY scales, global ratings, and we see here that acceptance, empathy, all these important MI skills were quite high in the brief MI and very low. So it really is what we expect. Also, a few behavior count that we have in the MIGHTY, and you see here again that it was quite good MI in the MI group, but very low level for the brief advice. And you see here that in the brief advice, they give a lot of information and a lot of advice without permission, which was what was expected. So fidelity was what we expected, very good. So this is the first primary outcome, heavy drinking days over the last months. And we see here that we have a significant time by treatment group interaction. And this shows that for the brief MI, actually it remained quite stable over the follow-up times. So at 1 month, 3 months, 6 months, and 12 months, here you see that flat line. So we believe that they decreased all to about 3.5 to 4 heavy drinking days per month. And then it remains stable for the brief MI, but it started to increase again for the brief advice. And this interaction here is significant. The other primary outcome was the SIP score, so the consequences of the short inventory of problems. And here we don't have a significant interaction. Nothing was significant in the model. And we see here that there is this flat line. So everybody is about the same over the follow-up. These are a few secondary outcomes, weekly drinking amount over the last week. And we see here about the same trend that brief advice increased a bit more, but here the interaction was not significant. Its score, we measured it at 0 and 12 months, and we see here that it decreases over follow-up time. So that might be this teachable moment that when you go to the ED, you decrease your alcohol problems. But it was the same across the two groups, no time by group interaction here. And we have a biological outcome, that's the ethyl glucuronide in a hair sample. And this gives an idea of chronic heavy use. So using this kind of 30 picogram per milligram of and you see here that we didn't have a measure for all people. About a third of the sample gave us a hair sample. Some had hair too short, some refused. We have a few missed appointments for the follow-ups, and it was canceled due to the COVID-19 pandemic. The hospital was not accessible for the last people in the 12 months follow-up. And so over this measure, we see here that everybody decreased the drinking, again, as we saw on the audit score. But again, this was not a significant interaction by group here. And we had the readmission to the ED, and here we see a very nice graph, but this was not significant because there were not a lot of readmission after one year. But you see that it was more important in the brief advice group, but this trend is not significant. And we had readmission in the ED while intoxicated, about the same picture, but again, no significant interaction here. And the last secondary outcome is this start alcohol treatment. So we referred all the people to treatment, all those that have a high audit scores. And you see here that being in the brief MI group would really increase by 3.7 fold the rate of those actually starting alcohol treatments. So conclusion, the brief MI model, as we implemented it in an ED context, might help young adults admitted with alcohol intoxication to maintain this lower level of heavy drinking days over 1 year. Our intervention also increased the likelihood of initiating specialized alcohol treatment, which is very interesting, we found. But the results were inconclusive regarding alcohol consequences, alcohol use overall, alcohol disorder score, so the OD score, and readmission to the ED. And so we will have further studies to examine potential intervention effect mechanisms and our effect modifiers. So thank you for your attention, and I'm really happy to follow up with some questions and discussion.
Thank you, Doctor. So as Doctor stated, we will be taking questions now. So please feel free to put your questions in the Q&A section. Oh, one person has raised a hand as well. Yes.
Do you hear me?
Yep.
Hi, Jax.
Hi,
This is
Lydia.
Lydia from Barcelona, Spain. Um, okay, well, thank you very much. I'm honestly very following your work on emergencies and intoxication because I think it's really relevant. So, congratulations again for all
Okay.
this incredible task and you are doing in 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 your unit. No, of course, I understand the difficulty of finding all the you mentioned inconclusive no areas, but they are very interesting. I think very interesting results. I think the initiation of treatment, I think it's amazing.
Yeah.
But I arrived a little bit late, and I couldn't listen to how did you implement it? Because with emergency staff or with on special staff going to the emergency setting? Because this is the controversy in our context.
Yep.
So we cannot do it with emergency staff. We have to always ask someone else to go and do it there. How did you do it in that occasion?
Yeah, it was exactly that. So the emergency department staff don't want to do that. They're too busy to handle that. So and we also wanted to have counselor or therapists that are really high
Train.
level, MI trained and supervised. And so we had our own team that would go there. It was only in the weekend, so that's when the young adults are mostly admitted in the ED. So that was on the Friday, Saturday, and
You
Sunday
are
mornings.
still booking these 3 beds or 4 beds in the nights, Fridays, Saturdays, always still this issue of the no? Okay.
You mean in Lausanne, that unit that we had? No, that was closed. It wasn't working that well because they really needed the medical platform. So most of the patients would stay in the ED because there were other, medical conditions going on. So we mostly worked in the ED within the ED units, and it works
Okay.
very well. So the implementation was very good and very nice collaboration with the ED staff. That when you come and you say, "Okay, I will handle your patient with alcohol problems," they were quite happy
Of course, they are very
to
happy.
let us know.
The only problem is for sustainability, how this can be sustained over, because this is one of the issues, no? I mean, you keep having to, it's not easy to sustain it.
Yes, with those results, I mean, we have really a good argument to say, okay, we want to stay and we want to have a team that go every end of the week on the Friday to Sunday and be there and handle these cases in the morning. And it is now pretty well sustained in
Okay.
this hospital. So hope it could
Okay.
also be the case in other places.
Yeah.
Congratulations.
Thank you.
I'm sorry, I'm sorry, doctor, but we have run out of time. There is another question, but I think we'll have to take that after the session. Thank you.
Okay. Yeah. Can we still
Yes. So
answer the question in the Q&A box
there are
after?
right. So the thing is that we really have no time, but if you can answer this one in the next 1 minute, then we can go forward.
Yeah.
Otherwise, we can answer it after this session. So what we'll be doing is sending it to you through another medium, and you will be answering it through that, either email or direct message.
Okay.
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 Right. Okay. So I'm sorry, the other participants who asked your questions, but we will be getting those answered. But we have run out of time. But thank you so much for the participation that you have shown in this session. Thank you, doctor, for that amazing presentation. We are very happy to have you. So thank you everyone for joining. Please move to the next presentation and see you. This is the end of the session.
Thank you for joining. Good night.